So we're all very excited about BCMA-targeted agents, which are now being investigated and are approved for myeloma. And these are namely bispecifics such as teclistamab, elranatamab. We also have the CAR T cells, ide-cel and cilta-cel, and then belantamab mafodotin is currently undergoing further evaluation in combination with bortezomib or pomalidomide. So this then lends itself to a number of different options for patients, particularly older patients, to try and ascertain what the best outcomes are. Clearly what we want to achieve is a very high efficacy rate with good response rates and overall survival improvements, but you also in the elderly population need to manage the toxicity profile. So with CAR T cells, we have to be very careful due to the risks of CRS and ICANS, but particularly with cilta-cel, there is this risk of latent neurotoxicities, which can be particularly damaging for older patients. Now, with the bispecific antibodies, they are extremely effective, but we do know that they increase the risk of severe infections. This is somewhat mitigated by less intensive dosing and by IVIG, but still carries a risk. So you have to be a little bit careful. And what we're going to be discussing is how we can optimize the delivery of the bispecifics to minimize that risk. And then finally coming to belantamab mafodotin, that is a very convenient way of dosing patients because you can give the dose, say every 8 weeks initially, and then stepping down to a 12-weekly maintenance schedule. But of course, the main side effect with that is ocular toxicity. And so you have to carefully manage the patient in terms of their eye symptoms to make sure that they maintain their quality of life. So really what it's all about is trying to personalize the treatment for the patient according to the efficacy need and the toxicity need.